Welcome everybody to lecture 11 on respiratory physiology. All right, so some of the functions of the respiratory system, as an overview, we have gas exchange, right? So breathing in oxygen, breathing out CO2, communication. So communication in terms of speaking, right? Acid-base balance. So this is something we're going to get into more detail, especially as we learn more about the respiratory system and the renal system, because those are the two systems that work together to help regulate the pH of our blood, for example. The lungs also contribute to regulating blood pressure because they have an enzyme called angiotensin converting enzyme, or ACE, that helps to convert angiotensin 1 into angiotensin 2, and angiotensin 2 plays a large role in our blood pressure. Blood and lymph flow. So when we breathe in, right, when we inhale, at least transiently, we create a vacuum so air can move into our lungs. And that can actually have an effect on blood and lymph flow because it creates a gradient for the flow of blood and for the flow of lymph. And so they'll actually travel more readily into our thorax, okay, towards that vacuum. And then the opposite's true, is if we exhale, we increase pressure in our thorax, then it would actually prevent blood or lymph flow. Now, the expulsion of abdominal contents, it's referring to the Valsalva maneuver when you're bearing down. And so this is when you hold your breath and push down, you force down, and it's the diaphragm can kind of help flatten and push down against your abdominal contents, and that can aid with things like defecation, for example. So there's a host of things that our respiratory system is involved in. All right, so we're gonna touch on quite a few of those now. Okay, so clinically we break up the respiratory system into an upper respiratory tract and a lower respiratory tract. You may have heard of like having an upper respiratory infection versus a lower respiratory infection, and the anatomic cutoff for that is the larynx. So let me just circle that so you guys can see that's the larynx. The larynx is actually where our voice box is, right? So that's, if you were to palpate that on the anterior aspect of your neck, you can actually feel that, and this is known more in layman's terms as like an Adam's apple, for example. So that's sort of the outer cartilage of that larynx. So anything above that is upper respiratory. So that includes things like the nasal cavity, the hard palate, the oral pharynx, the nasopharynx, basically the pharynx. Okay, the pharynx is a muscular funnel, if you will, that helps to guide food particles and whatnot into the esophagus. And also helps to prevent food, for example, moving back into your nose or something like that. But more on that to come in the GI lecture, so something to look forward to. You also have something called the epiglottis. And the epiglottis, you can see this is the base of the tongue over here. I want to use that my red marker. That's the base of the tongue. And the epiglottis is this little piece of cartilage there. And it essentially acts like a little trap door over the trachea because we breathe in through our nose and we also breathe into our mouths, but that's also connected to the GI system, and so we don't want food particles getting into our airways. Now the airway is located more anteriorly, so that's called the trachea. So as you're seeing here, that's the start of our lower respiratory tract, is the trachea, so it starts just below the larynx. And so that stays open, all right? It's patent, it's always open. And just behind that, just posterior to the trachea, is the esophagus. So they are close together there. And so the epiglottis, when you're swallowing food, we don't want the food to get into the trachea. So the epiglottis, when you swallow, actually comes down and covers over the trachea and prevents food particles from getting into your airways. Because obviously we want to keep the airways as clear as possible so that we can optimize gas exchange. All right. And of course, the food would then end up in the muscular tube, or otherwise known as the esophagus, and make its way into the stomach. Now, in the lower respiratory tract, we said there's the trachea, all right, which is anterior, runs midline, okay, into the mediastinum, okay, in the mediastinum, so it's in the superior portion of the mediastinum where the heart is at the inferior end of the mediastinum. And so it would branch on either side. You can't really see the branching too well, but you're going to have the trachea is going to bifurcate, we call it, or divide in two, one towards the right and left lungs, and then it further continues to divide. And then it's going to go to that's going to continue to divide on the right side into 3 lobes. So you have 3 lobes of your lungs. So you can actually see 1, 2, and 3 here. And only 2 lobes on the left side, which you can see 1 here and then 2 down here. From the posterior aspect, it would look a little bit different, so I'm just warning you about that. And you can see that we have a pleura that surrounds the lungs. So so a visceral and parietal pleura, just like we saw with the heart, how it had a visceral and parietal pericardium. We have a visceral and parietal pleura. So this surrounds the lungs, and in between those two is a little bit of fluid, very similar to what we saw with the heart as well. Okay. Okay, so the phases of respiration. So we're actually going to start with this lecture with phase 1 of respiration, which is the movement of air. It's just the bulk movement of air, something we call conductance of air. So this is taking the air that's in our environment, how we get it into our lungs, and then how we expel that air, so when we exhale. So we're going to talk about the physiology of that today. Phase 2, that's the exchange of oxygen for CO2 at the alveoli. So how does that exchange occur? And phase 3 is the transport of oxygen and CO2 in blood and exchange at the capillaries. So once we actually get the oxygen and the CO2, how does that exchange with the tissue, and how does the tissue exchange with the blood, and so on. So we're going to talk about those in the lectures to come. Okay, so let's talk about that movement of air, or the conductance of air, right? So we're talking about air coming from the environment into our lungs. And this cartoon on the left is actually one that's in your notes. And you can see as we breathe in through the mouth, in this case, or the nose, right? It's going to go into the trachea. The trachea then bifurcates, or divides into two, and that leads into the left and right lungs. Once they're inside the right and left lungs, those bronchi are going to continue to divide. And every time they divide, we call it another generation. So there's multiple generations as they continue to divide. And what this cartoon on the right is showing you is that these bronchi, which are large at first, they get smaller and smaller and smaller, just like arteries. When the aorta continues to divide, they get smaller and smaller and smaller until they reach the arterioles. Well, instead of arterioles in this case, we have a bronchiole. All right, so those are sort of some of the smallest bronchi that we have, but they get just a tad bit smaller with the terminal bronchiole. Now, the bronchi all the way down to the bronchioles and the terminal bronchiole, these are what we call conducting airways, meaning they're only transmitting the air to the alveoli, but there is no gas exchange occurring at this point. Now, once we get to the respiratory bronchioles is actually where gas exchange can start to occur, where oxygen can get into the blood and CO2 can leave the blood. All right, so that can occur. So that's where it can actually start. And then in the alveolar sacs, these are really the dead ends of the bronchial system, or the bronchial tree, if you will. And they tend to look like these clusters of grapes. And if you'll notice, these clusters of grapes, each one is surrounded or embedded with this, this network of capillaries that just surrounds in every single alveoli. And the idea is that as the air comes into this dead end zone, or these alveoli, we want to exchange those gases as optimally as possible. So every single one of those alveoli is going to have capillaries that are associated with it. Now, if you recall, for pulmonary circulation, we refer to the oxygen or deoxygenated blood as the venous blood, which is in blue here. But recall that this is the pulmonary arterioles. This is the arterial blood coming from the right side of the heart, right? So this is coming from like the right ventricle. And so this is carrying low oxygen. And it's going to create these capillaries that surround every single alveoli. And then it's going to become oxygenated. So it becomes red, which you can see over here. Becomes red, and that's now the pulmonary venule. So that's the pulmonary vein that's going to return to the left atrium that is now oxygenated. And so what you can see from this cartoon is that there's so many different capillaries because there are just so many, millions of these alveoli, okay? And this helps to increase the surface area within the lung. These lungs are not open, empty sacs. That would actually not be a very good amount of surface area. Having all these alveoli creates the surface area, or increase the surface area tremendously. Okay, so it gives us a lot more surface area for gas exchange. Okay, and these alveoli are very thin-walled. And if we come back to this drawing from your notes over here, this is looking at it like microscopically through one of the alveolar walls, where it's trying to show you that the width of an alveoli might be about 100 microns or so. So very, very small, and that the capillaries are actually in between these alveoli. So this could be another alveoli over here, another one's over here, and so that would be the empty air airspace, if you will. And then you can see these thin walls between the two capillaries on either side, or excuse me, between the two alveoli, and the capillaries are actually in between them, so they're really enmeshed. And this is great because this actually gets the blood in close proximity to the air that's going to be entering and exiting that alveoli. Okay, so we have the pleura, which I mentioned a couple slides ago, that this is akin to the pericardium. All right, this is connective tissue that surrounds, that adheres directly to the lung, which we call the visceral pleura. Okay, that's the visceral pleura. So that'll follow the contours of the lung. And then you have the parietal pleura, and the parietal pleura actually adheres to the walls of the inner wall of the thorax and over the diaphragm. Okay, the diaphragm domes up into the thorax when it's relaxed. Okay, so you can see that, that's over here. And the pleural cavity is actually the space between the visceral and the parietal pleura, just like we saw that with the pericardial space. And it has pleural fluid. And again, when the thorax is expanding and relaxing, that in this way we can help reduce the friction of the lung against the thoracic wall and so on. Okay, so now the intrapleural pressure. Now the intrapleural space, between the visceral and the parietal pleura, does have fluid in it, just like in the pericardial space. However, the intrapleural space is actually physiologically serves a more important role than the one we find in the heart. So, for example, that intrapleural space, it has a slightly negative pressure. So it's actually a vacuum, and in fact, it is not open to the air that we breathe in. The air should never be entering into that space. It's a completely closed off vacuum. So in other words, when we breathe in our air, that goes into the trachea, into the bronchi, and then ultimately into the lungs, all the way to the alveoli. At no point should that air ever be entering into the intrapleural space. Okay. Now, partly the space is actually a negative pressure because of the recoil of lung tissue, all right, and the tissue of the thoracic cage. All right. Now, what happens is these two tissues pull in opposite directions. So the reality is that lungs, they have elastic tissue in them. So when they're expanded, they'll expand easily because they're quite compliant. Okay. However, because of the elastic tissue that they have, elastic tends to want to come back down and kind of like a rubber band. You pull the rubber band, you let go, it snaps back. Well, the elastic tissue inside the lung wants it to recoil inward. Okay. Now the chest wall also has elastic tissue, but it's elastic tissue because of the structure of our bones and the muscles of everything else. It actually wants to expand outward a little bit. It actually wants to come out. The lungs want to go in and the chest wants to come out. So they're in opposition to each other, but they're both stuck to each other inside our thorax there. Okay? So they pull in opposite directions. And because they pull in opposite directions, that intrapleural space ends up becoming a little bit more negative because they're pulling in opposite direction, creating that vacuum space, and that creates a little bit more negative pressure, which I'll get into more in a little bit. In addition, the fluid that I talked about helps to reduce friction, but the fluid also helps to keep the lung adhered to the thoracic wall. It helps to keep it there. So the way the analogy I like to give for this is, if you imagine, like, if you're reading your textbook and you spill water on it, the pages stick together, right? That thin film of water between the pages tends to stick together. So the water in that pleural space helps to keep the lung stuck to the inside wall of the thorax there. Okay, so now let's talk a little bit more about that elastic recoil. So this cartoon is showing you here that the lung's natural tendency, because of the elastic tissue that it has, is to make it collapse inward. And in fact, if it wasn't adhered to the thoracic wall, it would actually collapse into a little ball. Okay, so in order to keep it expanded, it has to stay, attached to that the inner thoracic wall there. And so an important point to make here is that there's no other attachment for the lung to the wall. In other words, it's not physically tethered. It's connected there because of a negative pressure in the intrapleural space, and because of that thin film of fluid there that helps to kind of keep it stuck there. All right, but there's actually no connective tissue bridge or anything like that. Now, if you see that, you see these gray arrows are indicating that elastic recoil of the lungs, and then the thoracic wall, the outer wall there with the bones and the muscles and all, they also have an elastic recoil, but their recoil goes outward. In other words, the chest, its tendency is to want to expand out. The lung wants to collapse in, the chest expands outward. So you're seeing these arrows pointing out. So it's showing you two opposite directions for elastic recoil of the lung versus the wall. And what ends up happening is that since they're pulling in opposite direction, they're pulling, and then the intrapleural space remember the parietal pleura is connected to the wall there, and the visceral pleura is connected to the lung, and that intrapleural space, that gets pulled apart. When it gets pulled apart, it creates a more negative pressure. And just like in the cardiology portion of this course, we talked about the pressures in terms of millimeters of mercury. It's going to be the same thing that we're going to be talking about here in the lungs. So showing here pressure is -3 millimeters of mercury. Now -3, that's actually relative to our atmospheric pressure. So I just want to go over that real quick. That at sea level, I mean, since we're either in Manhattan or Long Island, depending on which of my classes was looking at this, we're at sea level either way. And so at sea level, the air pressure around us, okay, is 760 millimeters of mercury. That's our air pressure. The higher in altitude we go, the lower that pressure becomes. Okay, that's when people are talking about how the air is thinner and so on. All right, so this is our air pressure here at sea level. So we're going to use that as our reference point. That's our environmental pressure. So -3 millimeters of mercury is referring to that it's 3 millimeters of mercury less than atmospheric pressure. Okay, so in this case, that would be 757 millimeters of mercury if you want to put that number to it. Okay, so that's when they're saying -3. That's what that represents. And so that's the intrapleural pressure. So that's when we say it's subatmospheric. It's 3 less than 760. So therefore, it is what we call a vacuum. All right, it's a vacuum. All right, and again, no air gets into it. So any air that goes into the trachea and into the bronchi and into the lungs will not get into that intrapleural space. If there is air there, we're going to have some other problems that we'll talk about. Okay, so now I'm going to talk about an important concept referred to as the transmural pressure gradient. Now, transmural means across a wall. So this is a pressure gradient across a wall. And just like blood, how blood goes down its pressure gradient, air is going to follow the same thing. It's going to go down its pressure gradient. Okay, and we can have pressure gradients across a wall. In fact, it's a very important concept, especially when it comes to the respiratory system. So just a quick reminder from the previous slides, I told you that the lung wants to collapse inward. And if we look at this cartoon here, this is showing you a single lung, and it's representing the lung as this circle inside here, which I just circled for you. So that pink area, that's the inside of the lung. The outermost circle here, right out here, that is the thoracic wall. Now the blue space in between the lung and the wall is the intrapleural space. All right, that's the intrapleural space. Obviously, that pleural cavity, or the intrapleural space there, is greatly exaggerated. That would be a very, very small space in reality, but obviously for illustrative purposes, we're making it a little bit larger. Okay. Now, open up here would be the trachea, so the air leading into the lungs, which is again that pink circle. Okay. Now, as a reminder, the lungs, their tendency with the elastic recoil is to want to collapse inward. So I'm just going to draw some arrows pointing inward, and that's just to remind you that that's the natural tendency of the lung because of its elastic tissue is to recoil in. And then the thoracic wall, its tendency is to recoil outward because the elastin pulls it in an outward direction. So we have this sort of equal and opposite elastic recoil from each other. And in doing that, the intrapleural space, that pressure, that vacuum that's there actually becomes more negative as we create a larger volume there. And so it becomes more negative. And in this case, they're using the numbers I talked about in the previous slide. So 760 would be 760 millimeters of mercury, which is the atmospheric pressure at sea level. And inside the lung, it would also be 760 millimeters of mercury because it's open to the atmosphere. And so, of course, they would equilibrate if it were open to it. The intrapleural space, since it's being pulled apart by the elastic actions of both those tissues, is 756. So instead of saying -3 or -4 in this case millimeters of mercury, they're saying 756 millimeters of mercury, which again is a subatmospheric pressure. So let me erase some of these markings here so we can talk about the transmural pressures. Okay. Now the transmural pressure, that's a pressure gradient across the wall. So let's take a look at the atmospheric pressure again, 760. The pressure inside the intrapleural space is 756. The wall is the thoracic wall. So you see that's marked out for you over here. So that's the pressure gradient across the outer wall of our body. So that means air wants to kind of go inside that space. And in fact, if we were to actually poke a hole in our thorax, okay, the air would go rushing into that intrapleural space down its pressure gradient. But that's not the only transmural pressure gradient we have. The other one's marked off for you over here because we also have the lung wall. And so in the lung, yeah, inside the lung it's 760, which is the same as in the atmosphere. And in the intrapleural space, it's 756. So it's the same gradient, but it's in opposite directions. In fact, the lung, the pressure is pushing outward because it wants to get into that intrapleural space. So the pressure is outward. In the atmosphere out here, the pressure would be inward because it wants to move into that space. So it's just a matter of the direction of that gradient. Now this is an important feature because the fact that the lungs, the inside of the lungs have a higher gradient, all right, than the intrapleural space, this is actually what helps, this is primarily what helps to keep the lungs stuck and open against the inside thoracic wall, is the fact that the pressure in the lungs is greater than the intrapleural pressure, and so therefore it's an outward pressure that helps to keep the lung open and adhered to the wall. And in fact, that pressure of, say in this case, 4 millimeters of mercury difference, okay, pushing outward from the lung, is actually enough to overcome the elastic recoil of the lung. And so it's an important point, is that although we have the elastic recoil, remember that wants to move inward in the lung, the pressure gradient is pushing outward. So this is where the lung is in equilibrium. If we're not moving air at all right now, all right, we're not moving air at all, it's just simply at rest, okay, what you have is an outward pressure gradient and an inward elastic recoil. The two are in equilibrium with each other. All right. If I were to increase the pressure gradient, in other words, let's say I made the intrapleural space more negative. So instead of being -4, let's say I made it -8 millimeters of mercury. That would make the gradient steeper, and then the lung might actually expand out even more against that elastic recoil. Okay. So right now this is again at an equilibrium point where it's just resisting the elastic recoil. Now the airways, all right, just a quick review of the anatomy here. As we go from the trachea, which is the main, okay, anterior aspect of our neck here, just below the larynx, all right, it breaks, and over here you can see the number of tubes every time it branches. These are also referred to as generations. And so it becomes the bronchi, right, as it divides into left and right bronchi into the left and right lungs. And then they further subdivide, and it continues to go on, as you can see here, all the way till we reach the terminal bronchioles. And as I mentioned already, this is just conducting the airway. It's not doing any exchange, so we call it the conducting zone. However, when it branches beyond the terminal bronchioles and becomes the respiratory bronchioles, okay, now they can have actually little alveoli on them and so on, which you can actually see here in the cartoon, that can actually exchange. So we refer to this as the respiratory zone because we can actually get gas exchange at this level. So everywhere from the respiratory bronchiole all the way down to the alveolar sacs, which are like those clusters of grapes, so to speak. This is just a cadaver. You can just get an idea here where if you're looking at the rib cage, for example, over here, you can see this in purple. That's the diaphragm, highlighted in purple. So you can see how much the diaphragm actually domes upward into the thorax there, all right? And again, if we take a look at the cadaver over here on the right, they've removed all the organs, obviously. You can't see the lungs or the heart or anything like that. The trachea has been cut off, so you can see that over here. There's the trachea. That's been cut away. All right, but now you see just the diaphragm in purple over here. And you'll notice that over here on the right side, this is the left side, on the right side it domes a little bit higher because under here, this structure here is the liver, whereas over here would be the stomach. All right, that's where the esophagus, which you can actually see, this is the esophagus right here, will actually lead to the stomach there. Remember, the esophagus is posterior to the trachea. All right, now in terms of respiratory muscles, the primary mover to bring air into the lungs or exhale is the diaphragm. All right, so far and away, that's what we call the primary mover of respiration. So normally, if it's relaxed, it's domed upward into the thorax. And if we were to inhale, the first action is over here, which you can see in the drawing from your notes, is that arrow pointing down, so this is the diaphragm. The diaphragm, when it contracts, it comes downward. It flattens out. All right, it flattens out, and so that serves the purpose of actually increasing the thoracic cavity, the space there. All right, so it enlarges the thoracic cavity, and that's going to help pull air into the lungs, because as it increases the space there, all right, it's going to drop the pressure in the lungs, and that's going to drive air from the atmosphere into the lungs, because we've just created a gradient. Relaxation of the diaphragm, so when it stops contracting and just relaxes, it's going to go back into its dome type shape, and that's going to decrease the volume in our thorax and actually help to expel the air. So that's going to compress the lungs and help to get the air out. Now we do have other muscles that will help with inspiration. For example, the external intercostal muscles. So you can see that in the cartoon over here. Our ribs essentially they're hinged to our vertebrae. They kind of hang down a little bit. All right, and when you breathe in, it hinges them upward like a bucket handle. And what happens is that actually increases the diameter here of our thorax in this direction. All right, so that helps to actually expand the thoracic cage. So we're expanding it outward with the external intercostal muscles and the diaphragm, which pulls downward. So you have to remember the external intercostals help us to inhale. All right, and these are muscles located between the ribs, and they help to elevate the ribs. Now we have some accessory muscles. Now this is only typically used when we have what we call forced inspiration. So if we're trying to breathe in really hard, okay, or somebody who's struggling to breathe might start to use these accessory muscles, and that's actually a sign clinically that maybe they're struggling to breathe. So the sternocleidomastoid muscle, all right, sternocleidomastoids, which actually help us to turn our heads and so on, that could be used. So you can see somebody's neck. If you look at their neck when they're breathing, if they're really struggling to breathe in, you see their neck muscles are tensing. It's usually a bad sign that they're struggling. All right, that's also where the scalene muscles and the pectoralis minor muscles in the chest can all be used to help us to actually inhale. So in this cartoon, you can see the blue arrows. When the blue arrows that are pointing up are the ones that are used for inhalation. So for example, up here you have the sternocleidomastoid and the scalenes. And so these are located in the neck, and they're going to help to elevate that rib cage, to help expand the volume there to breathe in. The external intercostals, again, to help lift the ribs. And then the arrows pointing down here, the diaphragm, as the diaphragm flattens. All of that's going to be useful for helping us to breathe inward. Now, in terms of expiration, now it's labeled as forced expiration because the reality is to breathe in, we have to activate muscles. We have to activate the diaphragm and the external intercostals in order to breathe in. We don't necessarily need sternocleidomastoid or scalenes unless we're really forcing in the air. Expiration is a passive process. So all that requires is that we relax the diaphragm and the external intercostals. They'll go back into their original position, and that'll help the air be expelled from the lungs, and it's a passive process. But as you guys know, we can breathe out forcefully. We can really force the air out. So the muscles that are involved in a forced expiration are the internal intercostals. And again, that's only for a forced expiration. So they will contract, and these are the green arrows pointing downward. They pull the ribs downward, which makes the thorax smaller. You also see over here the rectus abdominis muscles, the oblique muscles. All right, if you ever try to exhale really forcefully, you can feel your stomach actually tensing up. So these are muscles that would aid in that, aid in actually making the diaphragm smaller and helping to expel. The abdominal muscles, when they contract like that, they actually make the abdominal cavity smaller, and that forces the diaphragm upward. Okay, so the respiratory muscles, all right, this is for expiration. As I mentioned already, normal, quiet expiration, this is a passive process. All right, basically the elastic recoil of the lungs, as well as what we call surface tension inside the alveoli, which I'll get to. This is going to bring the lungs back to its original position as long as our thorax muscles, the diaphragm, and the external intercostals are relaxed. It'll all recoil back to its starting position, or its equilibrium position, if you will. Of course, if we do a forced expiration, we're involving all the muscles that I've already mentioned. So contracting the rectus abdominis, the obliques, these will actually help to force the air out if needed. And in certain pathological conditions, you may see that occurring when patients are forcefully trying to get air out against an obstructed airway, for example. Now, in terms of the mechanism of airflow, we're talking bulk airflow. So I want to get the air from the atmosphere into my lungs, and from the air in my lungs to get it out back into the atmosphere. Okay. just like I mentioned already, and I mentioned in the cardiac lectures, is that this involves a pressure gradient because we're talking about flow. So I have to, of course, talk about Ohm's law again. So this formula will serve you well if you understand it, right? Is that the flow, now it can be the flow of blood. I talked about it in terms of the flow of blood, all right, but it's the same thing for air. All right, so flow of air, we'll say, is equal to the delta P over the R. So the delta P is the difference in pressure. So again, air is going to flow down its pressure gradient, just like blood did. And R is the resistance. All right, is the resistance to the flow of air. And we'll talk about that. The resistance to the flow of air is very similar to the resistance of the flow of blood in terms of diameter of the airways, the viscosity of the air versus viscosity of the blood, and so on. So it follows a very similar pattern with this. All right, so again, airway pressure gradient moves airway into or out of the lungs. In other words, at rest, if I'm not breathing in or breathing out at this time, all right, then there is no pressure gradient. The airway out in the atmosphere is the same as it's going to be the air in my lungs. Okay, so between breaths, no gradient, which means no airflow. Okay, inspiration. The pressure in the alveoli has to decrease. Remember, if I want air to go into my lungs, that means the pressure inside my lungs has to decrease. Now I've set up a pressure gradient, so air will flow from the atmosphere into my lungs. Okay, so that's what inspiration is all about, is how do I create that negative pressure? Okay, and that's what the muscles do. When they expand the thorax to the chest, all right, it actually creates more volume for the amount of air that's there, and that actually drops the pressure. And that creates enough of a gradient for air to move in. Now, expiration is the opposite problem, right? If once I'm at the end of my inspiration, I breathe in, and then it stops, right? The air doesn't flow anymore because the gradient is gone. Air flowed in all the way until it became in equilibrium again. When I want to expire that air, I have to increase the pressure in my lungs higher than the atmospheric pressure, so that air will flow out of my lungs and into the atmosphere. So in that case, that's when it's just the passive recoil can do that, or I could do a forced expiration. All right, so that's going to be air flowing out of the lungs. So it's dependent on this pressure gradient, and basically the muscles in our thorax are going to help us create the gradient so that air moves in and out. Now, another important point, though, is that the pressure is inversely proportionate to the volume. Okay, so again, this is an oversimplified view of Boyle's law. All right, we're going to assume really a constant temperature, if you will, because that would also affect this. But if I get a change in thoracic volume, I'm going to get a change in pressure. And so since they're inversely related, I could write it simplified, of course, like this. Say pressure is equal to 1 over the volume. All right, this is obviously a very simplified way of looking at it, but it does work for our purposes. So for example, if the volume were to go up, so draw the up arrow there, the volume goes up, then the pressure is going to go down. Okay, and it works like this. If we take a look at this cartoon, which is actually is a drawing from your notes, if we had, let's say, a glass chamber that had a rubber diaphragm, so it was completely closed off, all right, so there's a certain number of air molecules that are in that chamber right there. Okay, they can either get in or out though. Okay, they're closed off, so there's a certain number. They're going to be bouncing around inside that little glass chamber there, exerting a pressure outwardly against the walls of the glass container there, creating pressure. Now, if I were to take that rubber diaphragm and push it inward, let's say I pushed it into the glass container, I'm creating less space for the air molecules that were there. And so now they're really bumping into each other a lot, and it's actually creating less room for all those air molecules, and so it's creating a greater pressure inside that container. Okay, because I've actually decreased the volume, so the pressure went up. And then the reverse is true. If I took that rubber diaphragm in this last example and I pulled downward on it, I'm actually creating a little bit more volume, a little bit more space for the air molecules that were there, and so they're not going to be bumping into each other as much, and so the pressure actually comes down. And so we can just sort of simplify that relationship by looking at P equals 1 over V. So again, if the volume goes up, the pressure goes down, just like in this example right here. And the reverse is true. If the volume goes down, the pressure goes up. Now, obviously, this is a closed container, and our lungs are open to the atmosphere because we have the trachea, right, that allows it to have access to the atmosphere, and that's obviously why air moves. So when the diaphragm and the intercostals expand the thorax, all right, when they expand it, for the given number of air molecules that were originally in our lungs, when we expand the volume, the pressure goes down. When the pressure goes down, since we have an open access to the atmosphere, that air pressure now there's a gradient from the atmosphere into our lungs, the air moves down its pressure gradient inside our lungs. So that's why expand the thorax, right, outward, and the diaphragm downward creates a larger volume, pressure goes down, air moves inside our lungs. And then the reverse is true. As our muscles relax and they move back inward, they reduce the thoracic space, increasing pressure, okay, by reducing the volume there, and that creates the opposite gradient. The pressure in our lungs becomes higher than the atmosphere and air moves out. Now, pulmonary ventilation. So this is essentially breathing, right? This consists of inspiration and expiration. So we're going to talk about something called the respiratory cycle. This is very similar to when I talked about the cardiac cycle, right? The cardiac cycle was one whole phase of, relaxation to contraction back to relaxation again, and how the pressures change throughout that cardiac cycle. In the respiratory cycle, this is one complete inspiration and expiration. So we're just going through one inhale and one exhale. So that whole cycle. So quiet respiration, a few definitional terms for you. Quiet respiration means while at rest, it's effortless and automatic. So oftentimes we're not really even thinking about our breathing pattern, right? So it can just happen automatically. And so we call this quiet respiration, right? Now it's still, to inhale, it's still an active process. We still have to contract muscles in our diaphragm to make that happen, but we're just not always conscious of it. And then the forced respiration. So I can breathe in forcefully and breathe out forcefully. And so that's going to require more of a deep, rapid breathing, such as during exercise or something like that. Now, again, I'm going to reiterate, the flow of air in and out of the lungs depends on this pressure gradients. Okay, so again, its flow is equal to the delta P over the resistance. All right, so there needs to be a difference in pressure for flow to happen. Okay, so I'm going to walk you through the respiratory cycle and talk about the pressure changes and what's actually happening in the thorax and with the lungs as we go through one respiratory cycle of breathing in and breathing out. Okay, so we're going to start here at point A. All right, so at A, we are just about to inhale, but we haven't inhaled yet. Okay, so this is representing the pressure in the atmosphere. The pressure in the atmosphere is not going to change. That's going to be 760 millimeters of mercury at sea level, we're going to assume here. Okay, that means the pressure in the alveoli will also be 760 millimeters of mercury. Based on Ohm's law, flow is equal to the delta P over the resistance. There is no delta P here. From inside the lungs to the atmosphere, it's both 760, so therefore there is no airflow at this time. Now this is the intrapleural pressure. The intrapleural pressure, we're going to use the number that we've used in the previous slides. Let's say that's typically negative. It's going to be subatmospheric, meaning less than 760. So we'll call it 756 millimeters of mercury. So it's a negative 4 millimeters of mercury, all right, relatively speaking. And if you recall, that's going to create the transmural pressure gradient. So for the lungs, being 760 inside the lung and 756 in the intrapleural space, now I have a transmural pressure of about 4 millimeters of mercury. And that pressure is in the outward direction, which is going to keep those lungs open, right? Now we go to step B. Step B is I breathe in. Again, the atmospheric pressure is 760. I'm not changing the pressure inside the lungs just yet. We're going to take this a little bit at a time. So those pressures are still the same. No air is flowing yet. Remember, the first step to breathing in is to contract the diaphragm, so that flattens out and comes downward. And the external intercostals are going to help lift the rib cage, so we're expanding the volume of the thoracic cage. And by doing so, what initially happens in that expansion is that the intrapleural volume will actually increase. When that volume increases, just like I talked about Boyle's law, as that volume increases, the pressure is going to go down. So the intrapleural pressure, which was 756 to start, as it drops, is going to probably go down to about, let's say, 752 millimeters of mercury. All right, so it's even more subatmospheric due to that volume expansion. Now in C, the next thing to happen now is because the intrapleural space is 752, All right, and the inside of the alveoli, to start with 760, that gradient is now greater, which means that outward pressure gradient is now increased. So the lung is going to actually expand along with the wall there because of that pressure gradient that's been created, that larger pressure gradient. So the lung is going to move outward, and it's going to move outward, and it's going to overcome the elastic recoil at that point. Remember, the elastic recoil and the outward pressure gradient were in equilibrium before I started to breathe in. Because I created a larger gradient between the intrapleural space and inside the lung, now that pressure gradient is greater than the elastic recoil pressure, or that collapsing pressure. So therefore the lung expands and moves outward along with the thoracic cage. So in that case, as the lung expands, the inside volume of the lung now is going to increase, following again Boyle's law. If I increase the volume, the pressure inside the lung is going to go down, at least transiently. So you see here, here's the alveoli, the pressure has gone down, and typically the pressure will go from 760 initially. As the volume expands when we breathe in, it'll drop to about 759 millimeters of mercury. This is again quiet respiration. I'm not talking about forced inhaling and exhaling at this point. So it drops about 1 millimeter of mercury to 759. Now I have a gradient between my atmosphere and the inside of my lungs. Remember, the atmosphere is 760. The inside of my lungs now, because it's expanded, is 759. So the air, so you see this in D, the air now will flow into my lungs down the pressure gradient. And yes, 1 millimeter of mercury is enough of a pressure gradient to let air move inside our lungs. Okay, so that's what's happening. You got the air moves inside the lung. The intrapleural pressure remains very negative, so it has to maintain that that negative pressure of 752 in order to keep that outward pressure gradient to keep the lungs open. Okay, but now that the volume is expanded in the lungs and the pressure inside the lungs has dropped to 759, air now moves into the lungs down its pressure gradient, and it will do so until the pressure inside the lungs equalizes the atmospheric pressure again. So in this case, as the air moves in, the pressure inside the lungs will now be 760 once again. And this is at the end of inspiration. That's at the end of inspiration. So we breathe in. As you breathe in, the air moves in. At the end of, when you're done breathing in, the end of inspiration there, the atmospheric pressure is once again equal to the pressure inside the lungs. Now at point E is now where the start of expiration. So you see the arrows pointing inward. So that's when the muscles are relaxing, no longer contracting. So the external intercostals and the diaphragm relax. As they relax and come inward again, what's happening is this is going to decrease the thoracic volume. And so that has an immediate effect on the intrapleural pressure, which remember just before this was 752. The intrapleural pressure is going to go up again because the intrapleural space, that volume there, is actually going to go up. So it's going to go down, and so the pressure is going to go up. So it's going to go back to 756. As it goes back to 756, the transmural pressure gradient, of course, across the lung is going to change. Okay, so if you take a look at F, the lung starts to come back inward. All right, the lung recoils back inward because the pressure gradient has now been reduced. So the elastic recoil helps to bring it back until it reaches its equilibrium point, which is where we were at point A again. And now the pressure, since the volume in the lungs is decreasing, it's increasing the pressure inside the lungs. So remember, the atmospheric pressure doesn't change, it's 760. The pressure inside the alveoli now, as the lungs start to recoil backwards again, goes up. And again, we started out at 760 at the end of inspiration, and by the time the volume is reduced due to the elastic recoil during expiration, it'll usually go up to 761 millimeters of mercury. So now this pressure is higher than the atmospheric pressure, and that's going to drive air out of the lungs and into the atmosphere, and it will do so until it equalizes again, which is back to point A. Okay, so that respiratory cycle that I just went through could be demonstrated graphically, of course, right, as always. So here, this is just showing you inspiration and versus expiration and how the pressures and the volumes change during that time. So for example, if you take a look over here, we're talking about pressures, right? And this is, of course, atmospheric pressure, so it's in millimeters of mercury. And you'll notice that the pressures, they don't say 760 or 756, which is like the numbers I was using. Instead, it's saying +2 or -2, but that's relative to the atmospheric pressure. So 0 really just represents the atmospheric pressure, which is 760 millimeters of mercury. So +2 is just 2 above that, okay? So here you see there's two columns. There's an inspiration and expiration column. And so let's just take the first curve here. This is the intrapulmonary pressure. So this is the pressure inside the lungs. Okay, so we breathe in. Remember I told you that the pressure in the atmosphere is 760. Okay, and at the start, it starts at 760. So that's what 0 is. We're starting here at this point during inspiration at 760 inside our lungs. As we breathe in and the lungs expand, okay, the pressure goes down due to the Boyle's law, right? So the pressure goes down. In this case, as it goes down, the peak here that it reaches is 759 or -1 millimeters of mercury. So it becomes slightly subatmospheric, just like I described in the previous. And again, at the end of inspiration, however, remember, as we create that gradient, air is going to start to move into the lungs, and it's going to equilibrate. So that the time I'm done taking my breath, so I go, at the end of my breath, the air has already equilibrated, and there's no more gradient anymore. So at the end of inspiration, we're back to 760 millimeters of mercury. Now when you start expiration, again, you're starting expiration at 760. So at 760 millimeters of mercury, it's a larger volume lung, but as the lung then now recoils slightly, when it recoils and becomes smaller, the pressure goes up. And so you see pressure rises inside the lungs to about 761 or +1 millimeters of mercury. And then it's going to go back to 760 once it equilibrates at the end of expiration. So that's how that pressure changes there. Now, if we take a look over here, this is talking about the intrapleural pressure. So again, that's the space between the wall and the lung there. And that changes more drastically. So again, at -4, that means we're starting at about 756 millimeters of mercury. Okay, and when we breathe in, it continues to drop and stays low at the end of inspiration. It doesn't cycle because there's no air moving in there to balance it out or anything like that. Remember, it's a vacuum. So when we expand the thoracic cage, its pressure drops and stays low. So we have a drop to about, in this case, -6. Okay, and then when we start to expire and we decrease the volume again, the pressure starts to go up and back to the -4 starting point. Okay, so these graphs do look slightly different from each other, and again, that's because of anatomically where they're located. So now the difference again between the intrapulmonary pressure and the intrapleural pressure, that's our transpulmonary pressure, right? That's what I was describing before. So under normal circumstances between breaths, when I'm not breathing in, if this is, say, 756 in here and it's 760 in the lungs, right? The difference between those is 4. That's the transpulmonary, and it's outward, which helps to keep the lung open, all right? As they breathe in, though, right? As you breathe in, you're creating a larger gradient. Okay, so that gradient, so the intrapleural pressure drops to -6 in this case. In this case, it would be 754, and the lungs are still 760, and so therefore there's a larger gradient, and the lungs expand outward against that elastic recoil. So it overcomes the elastic recoil and is able to actually open up more. Then finally, the volume over here. This is just showing how the volume changes in the lung during each breath. So again, remember, this is divided from inspiration to expiration. So when we breathe in, this is again normal, quiet inspiration, not forced inspiration or expiration. So as I breathe in, I take that breath, my normal breath in, it goes from my baseline, whatever that was, we'll talk more about that in a minute, from my baseline to up to about half a liter. So this is in liters, by the way. So this is half a liter, so 500 mLs. So it goes up when I breathe in. The amount of air that I'm actually taking in at the end of inspiration is about 500 mLs or half a liter. And then when I expire that same volume. And so that's going to be half a liter out. So in point of fact, a small change inside the pressure, right? So inside the pressure of our lungs. So when we create negative pressure in our lungs, we're only changing it by about 1 millimeter of mercury in either direction. So when we breathe in, we drop the pressure by about negative to -1, and that's enough to bring in 500 mLs or half a liter of air. And then when the pressure increases by +1 or +1 millimeter of mercury, that's actually enough to drive out 500 mLs or half a liter of air. So we're able to move half a liter, breathing in and then breathing out, just on our normal quiet respiration. Okay, so this is just showing you here sort of a pathologic situation where we have something called a pneumothorax. This is where air gets into that intrapleural space. So if you recall, that's a vacuum. There shouldn't be any air in that space at all. It's not connected to the respiratory pathways there under normal conditions. But sometimes you can have situations where air can get into that space. And if air gets into that space, what can happen is we can lose the gradient that helps to keep our lungs open. And remember that without the pressure gradient to keep it propped open, then it's just the elastic recoil, and that can cause the lung to collapse. And so here, this is a situation where it's closed. What that means is that the thoracic wall is undamaged, but the lung itself, you might have had what we refer to as something called a bleb, for example. And this is like a weakened area in the lung, and it can kind of burst like a bubble, if you will. And then now it's the air that's in the alveoli can actually get into or escape into the intrapleural space, and it's going to equalize pressures quickly. And when it does that, the elastic recoil takes over, and you can see the lung actually collapse inward. In an open pneumothorax, this means the thoracic wall was punctured, maybe from like a stab wound or a gunshot or something else, some sort of trauma. And like I said before, now we also have the pressure gradient from the atmosphere that wants to get in there, right? And so air will come flooding into that space there and equalize, and it's the same result. It just allows the elastin to actually let the lung collapse then, even though the lung itself may be undamaged. In fact, on this X-ray, you can actually see here, if we're looking at a chest X-ray, I'll just point out to you here, this is of course the outline of the heart over here, okay? You can even see the aortic arch over here. Again, it's not stuff you need to know at this point here, but anyway, you see the lung. Here's the lung field over here. That's my left lung, not my left lung, but the patient's left lung, okay? And you can actually see some of the vasculature in that lung. If you look over here at the right lung, so over here would be the right lung, you can't see any vascular markings there, all right? That's not because it's a super clean lung, clear lung, or a good picture or whatever. What you're actually seeing is here's the outline of the lung. All right, this is all air space in here. This is all air. So in point of fact, in this case, it's a pneumothorax that you can see on a chest X-ray, where the lung has collapsed inward due to pressure, the air getting inside that intrapleural space. Okay, surfactant. So I mentioned earlier that the recoil of the lungs is in part due to the elastic recoil. That's one of the main contributors. Another contributor to that is what we call surface tension. And so surface tension is something we're referring to the tension on the surface of a fluid, like water. And in fact, we do have surface tension in our alveoli because the alveoli have a thin film of fluid on the inside of it. So you can see over here in the cartoon, this is one of our alveolus, just a single alveoli, which you can see here. It has multiple different types of cells that surround it. So over here, just so we're clear, this is a capillary. All right. Here's another capillary. You can see a red blood cell inside that capillary. And then we have an alveolar macrophage, which is really just an immune cell there. And then you have a type 2 alveolar cell, all right, and a type 1 alveolar cell. So a type 1 alveolar cell are really thin and kind of make up the most of the wall of the alveoli. The type 2 alveolar cells are a little bit shorter and bulkier here, and these are actually the ones that produce a substance called surfactant and release it onto the surface of the alveoli. All right, and you can actually see, if you look closely here in this cartoon, that little blue line that you're seeing on the edges of the alveoli, that's this little thin film of fluid that surrounds the inside of the alveoli. The rest of this sort of beige area right here is actually where the air would be, so it's an open air space. All right, so you can see a thin film of fluid around the edges of the alveoli. And this helps with gases to be exchanged across the surface here. So it's an important piece to have that fluid there. Now, the issue with that, though, is once we have any kind of water on the surface, it can create surface tension, all right, because the water molecules that are on the surface, remember water molecules in general are polar, and they interact with each other, and so in a three-dimensional space, water molecules would interact with each other from above to the sides, below, and they would pull on each other and bring everybody together inward. However, on the surface water molecules, they can interact from side to side and downward because that's where the other molecules are, but it can't interact upward because there's no other water molecules above it. And so what that does, that tends to pull all the water molecules on the surface together, side to side, and then downward. And that can create what we call surface tension. All right? And so we refer to that as a force that's generated when water meets air. So anywhere time you have water and the interface between water and air, we have surface tension. Okay, so that was surface tension, right? So the surface tension, their tendency is for these water molecules to pull each other together from side to side. And if you have a spherical alveoli, what ends up happening is they pull each other closer and closer together. And the idea is that the water molecules will try to interact more and more with each other, such that it would actually have a tendency to pull the alveoli, make the alveoli smaller, and kind of collapse on itself. So the fact that we have a little bit of water lining the edges there, and the fact that those water molecules will interact with each other and pull on each other, means that that makes the alveoli have a tendency to collapse inward. So not only do we have the elastic tissue, which is the connective tissue dispersed throughout the lung, that makes it collapse inward, we also have this surface tension in the alveoli. And we have millions of alveoli, and so the surface tension can be quite significant. All right? So surfactant. Type 2 alveolar cells secrete this surfactant. And surfactant is essentially acting like a detergent. And so what happens is it gets in there, it has both a hydrophobic and hydrophilic component. And it acts like a buoy, if you will, inside the water. And this actually disrupts the interaction of the water molecules. They can't directly interact with one another when you have this buoy of surfactant that's interspersed with them. And in fact, surfactant works best when the alveoli are smaller, because when the alveoli are smaller, it scrunches up all the surfactant together, and they actually become more effective in preventing water molecules from being able to interact with each other adequately. And the net result of this is since it's preventing the interaction of water molecules with one another, actually reduces the surface tension. It breaks up the ability of the water molecules to interact, so therefore the surface tension goes down. So it reduces the surface tension, which means it's easier to open up the alveoli. It means there's less collapsing pressure on the alveoli, so they open up and it can expand more. So surfactant is really important for that. So when we try to breathe in and we're overcoming that elastic force, we're also trying to overcome some of that surface tension force, but that we're helped with the surfactant in that. So it makes the lungs, in essence, more compliant. It also prevents air from shifting from small to large alveoli. Because what happened, generally speaking, is that not all alveoli are made the same size. They're not all equal size. Some are smaller than others, some are larger. And so what happens is the smaller ones would have a higher tendency to collapse, because the smaller they are, the more the surface tension takes hold and would draw it into collapse completely. The result of that was, if you have all these small alveoli collapsing, any air that was in that alveoli would get shunted into any of the other alveoli that are around, and they might actually become larger. That's not optimal, okay? Because then we're going to lose surface area. So the idea here is that we want the small alveoli to remain open. We don't want them to collapse on themselves. So the surfactant actually works better in those smaller alveoli, as I mentioned. It actually is more effective. And so it reduces that surface tension. It's going to reduce air shifting to larger alveoli because these smaller ones are collapsing. And then finally, also prevents pulmonary edema. Now, this is actually an issue, especially in premature babies. If they're born before a certain time during development, what ends up happening is they don't produce enough surfactant yet. And so it's hard for them to open up their lungs. So this is why a lot of them may need to be on respirators and to be treated for it. Treated with steroids and so on that help to produce the surfactant. And so, it's important for that. But in addition, some of these babies that are premature, they can get a lot of pulmonary edema from this. And the reason is if it's hard for me to expand the lungs, right? Because in a normal healthy adult, to expand the lungs, what I need is to have that pressure gradient, that transmural pressure gradient that has to be steeper. That helps me to open up the lungs. The lungs are fairly compliant because I have surfactant, right? So that helps them to open up. However, if let's say I don't have the surfactant yet, as like these infants may not, then I need to create a much larger transmural pressure gradient in order to open up my lungs because they're not as compliant. So I really have to kind of force it open. So the steeper transmural pressure gradient, that creates a much more negative pressure that I have to reach just to open my lungs. That can actually draw fluid out of the capillaries. Back to those Starling pressures. Remember, there's the hydrostatic pressure and oncotic pressures and all that good stuff. This basically creates a very, very negative pressure in the interstitial space that actually draws fluid out of the capillaries and can fill up the lungs. And so they can, they can become edematous. And basically this is just because they're trying to force air in and creating larger pressure gradients in the interstitium there. The last thing I want to touch on here, if you take a look over here, and I don't expect you guys to really do these calculations, but I'm showing this to you as sort of proof of the principle I've been referring to. So over here, this is the lungs, or not the lungs, I should say. This is the two alveoli. So you can see a smaller one and a larger alveoli. And there's a formula referred to as Laplace's law. And so that's this formula right here. So the P is actually the pressure of collapse. So it's the tendency to collapse. So that inward pressure of collapse. And it's equal to 2 times T. So T is the surface tension. And it's divided by the radius. Okay, so just to give you an example, in this alveolus over here, the smaller one, you can see that the P sub 1 equals 2T, so 2 times the surface tension. All right. What if I tell you now that the radius, we'll just say the radius is 1. If I do the calculation for that, and I just substitute 1 into the radius here, all right, you'll see that 2 times T over 1 is just going to be 2T. So it's going to be 2 times the surface tension there. There's no surfactant in this example right now. And in the larger alveoli, we're going to say the radius is 2. Okay? If the radius is 2, again, it's going to be 2T divided by 2. Well, the 2's would actually cancel out. All right, so I'm just left with T. So if we compare the two of the smaller alveoli, which is this one, compared to the larger alveoli, the smaller alveoli has twice the amount of surface tension, meaning the smaller alveoli is more likely to collapse on itself. Now, if I look at B down here, it's the same setup. We have the smaller alveoli and the larger alveoli, but now these little dots down here, those represent the surfactant. So the surfactant is interspersed between those hydrogen molecules, or the H2O molecule, excuse me. And so again, let's just say now the surfactant, all right, is very effective, more effective in a smaller alveoli. So it can actually decrease the surface tension to about half, all right, when the radius is 1. So if we substitute that into our formula over here, if the radius is 1, all right, 2 times 1/2 T is just T. I crossed out the thing. They made a mistake on in their book there. So it's just T, all right. And then if we take a look here, if the radius is 2, all right, the surface tension is still just T there. The surfactant is not as effective in a larger alveolus. So it's 2T divided by 2, so it's still T. So what happens is here is this. Is that now in both the small alveoli and in the large alveoli, the surface tension, all right, or the pressure of collapse, I should say, the pressure of collapse is exactly the same as in the small versus, no longer is the small one more likely to collapse than the large one, and that's due really due to the fact that surfactant is far more effective in a smaller alveoli. That's really the take-home message, okay? So now we'll talk about respiratory volumes and capacities. So when we do our quiet respirations versus when we forcefully inhale or exhale. Okay, so this is a graphic visualization of respiratory volumes and capacities. So this is actually a graph you guys need to know and need to be familiar with. All right, so you can see on the left axis over here, this is lung volumes in milliliters. Okay, and it goes anywhere from 0 down here. You can see up to about 6,000 mLs or 6 liters. This is a typical volume, about 6 liters, a typical volume for an average adult. However, that can vary depending on the size of the person, of course. Now, what you're seeing here is this is actually over time. So even though it's not shown here, the x-axis is time. So the person is breathing here. So in yellow, what you're seeing here, this upward deflection, Anytime you see an upward deflection on this graph, that's the person breathing in, or they're inspiring. Anytime you see the downward deflection, it's expiring. And so they have, of course, the device in their mouth, and they're just breathing in, breathing out, and it's recording the deflections there, the volume, the changes in volume as they're breathing in and breathing out. And as you guys know from the previous slides, during the respiratory cycle, during quiet respiration, we move half a liter of air. We move, half a liter comes in, we breathe in, half a liter goes out, we breathe out. And if you take a look here, our tidal volume goes up. You'll notice that this upward deflection is actually half a liter. If you take a look over here, this is about 2.5 liters right here. So it goes up to 3,000. So 2,500 to 3,000 is 500 mLs. So we breathe in 500 mLs. We breathe out 500 mLs. And so that's why we're seeing these little waveforms here. This actually represents our quiet respiration, and that's our tidal volume. And in fact, you'll notice that when we breathe out that 500 mLs, we're not at zero. We're at 2,500 mLs. That's typical. We have about 2.5 liters, because if we were to try to expire forcefully, right, as you can see over here, we breathe out forcefully, we actually still have air in our lungs. It's actually important because it gives us an ability to expire forcefully, but also that other volume in the lungs actually helps to keep the lungs patent or open. Okay, so it helps them to keep them from collapsing. And so here, if I were to expire forcefully, I'm tapping into what I call my expiratory reserve volume. So the expiratory reserve volume is the volume that I can exhale beyond my typical 500 mLs from my tidal volume. So that's why this little blue line here that you're seeing there, this is the expiratory reserve volume. That's how much I could actually exhale. Now you'll notice I can't exhale all the way to zero. It's impossible, physiologically speaking. So as hard as you try to breathe out, you cannot access what we call the residual volume. Residual volume is typically about 1 liter to 1.5 liters, and that's volume that just is not accessible in terms of being able to exhale that. And of course that's important because we need that air to help prop open and keep our lungs open. Now if I wanted to try to breathe in above my typical 500 mLs, that would be my inspiratory reserve volume. So that's me trying to breathe in forcefully. And if I try to do that, I could actually increase the volume I take in. Above my quiet respiration, I could increase another 3 liters. Okay? So it's a substantial volume there. So those are the volumes: expiratory reserve volume, inspiratory reserve volume, and my tidal volume. And then there's the residual volume. Those are the different volumes, right? Now, if I start to combine those volumes together, I get capacities. So for example, the vital capacity is the total amount that I could forcefully breathe in and breathe out. That's basically the total amount of air that I can move, okay? Because I can't touch the residual volume. So the total volume that I could actually move is called the vital capacity. So you can see that includes the inspiratory, the expiratory, and the tidal volume. The functional residual capacity is the total volume in the lungs that is not remains in the lungs when I'm just doing my tidal volume. The inspiratory capacity is the total volume that I can move trying to breathe in from the start of my quiet respiration, all right, until into inspiratory reserve there. So it includes inspiratory reserve volume and tidal volume. And then lastly, the total lung capacity is the entire amount of volume in the lungs. Okay, vital capacity is the amount I can move. Total lung capacity is the total amount, which would include the residual volume. Okay, so now I want to talk about minute ventilation. Minute ventilation is equal to the tidal volume times the respiratory rate. What this is actually telling us is the volume of air moving through the lungs every minute. And this is actually just like what we talked about with cardiac output in the cardiovascular lecture, where cardiac output was equal to the stroke volume times the heart rate. Right? That was telling us the volume of blood that was moving every minute. And so that would usually be on the order of anywhere from 5 to 6 liters per minute, for example. Minute ventilation follows the same formula. We're now, instead of talking about blood, we're talking about air, right? So the flow of air every minute. So it's approximately 6 liters per minute, very similar to our average male adults, which would be about 5 liters per minute of their cardiac output, right? So this is 6 liters of air per minute at rest. So for example, if the respiratory rate was 12, which is a typical respiratory rate, so that's 12 breaths per minute, and a tidal volume of half a liter or 500 mLs. So half a liter. All right. So again, the tidal volume is the volume of air moved with every breath. So this is half a liter per breath times 12 breaths per minute. And what you end up with is 6 liters per minute. That's the volume of air that's moving at rest. So of course, if you were to exercise, just like with your cardiac output goes up to accommodate the exercise so that it can match the metabolism of the tissue. The lungs, of course, are required for that as well, right? So they have to actually be able to bring in the oxygen that the tissue requires. So we have to be able to move that volume. And so when you're exercising, if your respiratory rate goes up, which it does, okay, also the amount you breathe in, the volume of air you're exchanging goes up as well. And so naturally, either one of those would increase the minute ventilation, and they can go upwards of like 50 or 60 liters per minute during exercise. And so that's well above the 6 liters at rest. We saw that with cardiac output. When the cardiac output is, say, 5 liters per minute, I told you that cardiac output could increase 4 or 5 times as much. So you could have anywhere from 20 liters per minute of blood circulating versus, like, say, somebody who's like an Olympic athlete who could make it about 35 liters per minute. It's the same kind of principle here. So this is actually referred to pulmonary reserve, which is the amount you could actually increase it, the range you could increase it above your resting minute ventilation. How high can it go? Same concept as cardiac reserve. How high does your cardiac output go in response to the exercise? So this is in similar principle. So obviously, if you're exercising, the oxygen demand would go up. So we're going to need to be able to move more air into our lungs. Now, spirometry, which is actually what I was talking about when I went over all the different capacities and lung volumes with you. All right, we use that to help us diagnose certain pulmonary diseases. Right. So this is actually the measurement of pulmonary function. So we call this a pulmonary function test. All right, or PFTs. And we'll do this on patients who we suspect have some sort of airway disorder. Okay, and this helps us really to classify diseases into 2 main categories, either as restrictive or obstructive. Now, there still might be more work that needs to be done to kind of tease apart sort of the subtypes of restrictive and obstructive, but this helps to give us that categorization. So, for example, a restrictive disorder, a lung disorder, is any kind of disorder that reduces pulmonary compliance. So remember, the lungs want to expand when they fill with air, and so they change to a large volume with very little pressure. So it doesn't take a lot of pressure to really make them expand. And so that means it's very compliant. It can hold a large volume for very little pressure change. So and that would be a typical healthy lung. However, in a restrictive disease, it's going to reduce that compliance. So it's not going to expand for a given pressure change as readily. So things like infections like tuberculosis, or anything that can cause scarring of the lung parenchyma or tissue, is going to make it more restrictive. Okay, so this is going to limit the amount the lung will actually inflate. So we call that a restrictive disorder. An obstructive disorder is just as it sounds, going to obstruct airway. So this is going to interfere with airflow by either like narrowing the airway or blocking it. So an example would be like COPD, like a chronic obstructive pulmonary disease. Ones like asthma. All right, asthma actually causes constriction of the airways. So you can get some constriction. Constriction of the airway would actually increase the resistance to airflow. So just as a quick reminder here, flow, and I know I've drawn this already before, so hopefully you'll have it memorized by now, is delta P over R. Just like with blood that we saw in the cardiovascular lecture, if the blood vessels constrict, that increases resistance to blood flow, and so the blood flow goes down. Airflow is the same way. If the airways constrict, it's going to increase resistance, and therefore airflow goes down. So asthma reduces airflow into or out of the lungs. Bronchitis. Bronchitis is usually an inflammatory reaction where there's lots of production of mucus, and you can narrow the airways that way. They can even plug up airways and completely block some of the alveoli entirely, and so they can completely obstruct it. And so, of course, this is going to be very high resistance, and there's not going to be any airflow in certain parts of the lungs. So again, that's going to reduce flow. And then emphysema. So emphysema this is really more of a loss of supportive tissue, or the parenchyma that surrounds it. So with that loss of supportive tissue, it's not scarring, where scarring makes it restrictive. It's some of the loss of it, so it actually becomes more collapsible and a weaker structure overall. Okay, and so ultimately what ends up happening is it makes breathing in or out harder. It makes it harder to do. And so oftentimes with obstructive, if they get the air in, they have a hard time getting the air out. All right. Typically for people with obstructive disorders, it's easier for them to breathe in than it is to breathe out. Okay. And the reason is this. Looking back at our Ohm's law up here, the flow of air, as we breathe in, and we take an inhale, the lungs are expanding. When they expand, they actually stretch the respiratory bronchioles, the terminal bronchioles, and all that. They're connected to the parenchyma that surrounds them, the connective tissue that surrounds them. So as the lung becomes stretched and compliant and opens up, it actually pulls on the airways, and the diameter of the airways increases. So if the diameter of the air is increasing when we breathe in, that means the resistance to airflow is going down. Again, because the diameter is increasing. So resistance goes down, airflow goes up. So even if it's slightly restricted at rest, when you breathe in, you're actually kind of pulling it open a little bit more. And so the resistance goes down slightly. So it's easier to take an inhale because of that reason, because flow would be easier. However, when they exhale, when you try to breathe that air out, the air gets stuck behind or gets trapped. We call it air trapping, because as you breathe out, you're decreasing the size of the lungs. And so therefore the airways are actually becoming more constricted. And they may even become more constricted than they typically are even at rest, okay, as you're trying to forcefully exhale or breathe out. And what ends up happening is they collapse as well, and it may be difficult to get the air out then because the resistance is going up as you exhale. And this is actually a normal physiological phenomenon, that when we breathe in, resistance to airflow goes down, and when we breathe out, resistance goes up. It's just that the resistance is pronounced in people who already have restricted airways. And so they can become what we call barrel-chested. They can hold on to a little bit more air because the resistance goes up and it's already an obstructed airway. So it can be difficult for them to exhale. So generally speaking, usually we see more difficulty with exhaling than inhaling. Okay, so now to actually measure those lung volumes using spirometry to help us figure out whether or not something is, say, restrictive or obstructive or normal. So there's a couple of volumes we're going to look at. So first off, when they get the spirometer, right, we're going to try to measure what we call a forced vital capacity, or an FVC. The vital capacity, just as a reminder, we went over this a couple slides ago, this is the total volume of air that you can move in your lungs. So when you take a deep inhale, you're going to inhale as much as possible, and you're going to exhale as much as possible. So that total volume is your vital capacity. It doesn't include residual volume. It's the only thing that's not included in the vital capacity because the residual volume doesn't change. We can't move that air. Now the forced expiratory volume. So forced expiratory volume sub 1, you see a little sub 1 there. That means when I try to forcefully exhale, what is the volume that I'm exhaling and how much can I exhale in 1 second? So the 1 stands for 1 second. So it's the maximum amount of air you can exhale in 1 second. All right. So for example, if I take a very deep breath in and I exhale, when I exhale, the volume that I exhaled in 1 second might be 3 liters or 4 liters or something like that. Now the FEV3 is the maximum amount of air that I can exhale in 3 seconds. So it's just another marker. The FEF is the forced expiratory flow. It says 25 to 75%. What that means is really, I'm going to show you on the graph on the next slide, but we can actually graph out the flow. Okay, just like we saw with the spirometry readings, we mapped out tidal volumes and vital capacities and so on. So we can see the flow when the person's using the spirometer. And so we'll mark at the 25% mark is 25% of the volume that's been expired. And then at 75% point, when 75% of the volume has been expired. And between those 2 points, we can draw a line, and then we calculate the slope of that line. And the slope of that line gives us the rate of flow. And that's a good indicator of certain types of diseases, which I'll show you in the next slide. And then lastly, one of our most important variables here is actually this ratio, where we take the expiratory volume in 1 second, and we make it a ratio of their total vital capacity. So in other words, let's say I can exhale 4 liters of air, okay, in 1 second. Well, how much of that is of my total capacity? So if a normal adult's capacity is going to be, or an average adult capacity would be approximately 5 liters. So let's say this person's vital capacity is 5 liters. They exhaled 4 liters, okay, in 1 second. So that's about 80% that they exhaled in 1 second. And normal is approximately about 80%. That would be a normal FEV1 over the FVC ratio would be 80%. So let's talk about now when things are not quite so normal. All right, so this example is from your notes. And so what it's showing you here is 3 different scenarios. So top scenario here, I'll just label this as A over here. This is the normal. And we're going to read it from right to left. So what you're seeing over here, that's the tidal volume. All right, you can see volume is actually here on our y-axis. It's in liters. It's over time. All right. You'll notice that there's a little mark called residual volume down here. The residual volume is actually not marked on our y here. All you'll notice in this particular example, the dotted line up here, the peak, when we tell him from a tidal volume to breathe in as hard as he can, that total volume that he's going to reach is approximately here about 5 liters. All right, he's reaching a maximum of about 5 liters. When he breathes in, and we're telling him exhale as forcefully as you can. So when he exhales, you'll see that this is dropping, and here's the 1 second marker. So that would be the mark for our FEV1, and that's at this point right here. And you'll notice that he's exhaled, starting at about 5 liters up here, he's exhaled to about approximately 1 liter right here. So he's exhaled 4 liters out of the 5 total liters. The 5 total liters is his vital capacity. That's the total volume of air that he can move, is 5 liters. We don't see the residual volume here because that's not air that he can move. So in this case, he is exactly at 80% if we take that ratio, right? Because he's exhaled 4 liters and he has a total vital capacity of 5 liters. So that would be 80%, which is normal. And the FEF, 25 to 75%, is the slope of this line right here at the 25% mark and at the 75% mark. And so that slope, in this case, is a normal slope. All right, so this is our normal guy right here. And normally we would mark it. You don't have to worry about exactly what the slope is. We just say, the FEF is normal. The FEV1 over the FVC is 80%, and his total vital capacity is about 5 liters. So this is normal. Now, if we take a look at B here, so in B, again, we're starting with our tidal volume, so just breathing in normally. It's, is half a liter in and out. Then he breathes in as hard as he can. And you'll notice the total volume. You always have to pay attention to the total volume. That's 4 liters. So his vital capacity right now is 4 liters. Then he exhales as hard as he can, and you'll notice that the slope of this line is quite different. In fact, by the time he reaches 1 second here, if we look over here, that's about 2 liters. So he starts out with 4 liters, and he exhales as hard as he can, all right? And he's only able to get out 50%. You only drop 2 liters out of that 4. So that's 50%. So in this case, the FEV1 over the FVC is equal to 50%. 50%, that's less than the 80%. All right, that's less than the 80%. And you'll notice that even at 3 seconds here, he still has quite a bit of volume left relative to our healthy individual. Okay, it's taking him a lot longer, and you'll notice the FEV1, 25 to 75%, the slope of that line is reduced. So that has gone down. So the FEF is reduced. His ratio is less than 80%. All right, and his total overall vital capacity is less. This is a classic obstructive pattern. It's obstructive for this reason. When he breathes in, remember, it's easier to breathe in when it's obstructed. And then when he tries to exhale, he has a hard time getting the air out because the resistance to that airflow. So he's struggling to get the air out, so not as much air is leaving at 1 second. Not as much gets out at 2 seconds and 3 seconds. It's taking a lot longer to get the air out because there's obstruction to that flow. And so that's why that ratio, telling us about 50%, is a good indicator of obstruction. It's going to be less than the normal, less than 80%. And the FEF, that slope, is decreased, which is another good indication of an obstructive type lung disease pattern. Now again, it's not specifically telling us what type of obstruction, but that we can see that there is an obstruction. C here. All right, so C is obviously going to be our restrictive pattern. Again, you see the tidal volume over here. He takes a deep breath in, and his maximum volume is basically just a little over 3 liters here. So this vital capacity is greatly reduced. The amount of air that he can move is only 3 liters. Exhale as hard as he can. When he exhales, you'll notice that he exhales at 1 second. He almost exhales the entire volume. So almost all of that 3 liters is exhaled in 1 second. Okay, or at least very close, maybe 90% or so. Okay, so in that case, we might actually have a ratio that's about 90%. All right, this is greater than the 80%. Having equal to or greater than the normal. So in fact, in restrictive diseases, the ratio of FEV1 over FVC can be the same, about 80%, or actually even a little bit greater. And the reason is this. I'm going to draw it over here. If the FEV1, all right, at 1 second there, again, that's about 3 liters. So in this case, that volume is reduced. Okay, it has gone down for sure, but the total vital capacity has also gone down. So the forced vital capacity has also gone down, and they've gone down in proportion to each other, generally speaking. So that since they've both gone down, usually the ratio ends up looking the same, or sometimes the FEV1 goes down a little bit more, and so the ratio can be a little bit higher than 80%. All right, and so in this pattern, if it's restrictive, it's not really a compliant lung, so it doesn't expand all that well. So I can't bring in that much air, which is why the vital capacity is smaller. All right, there's no resistance to the flow though, so I can breathe it out pretty quickly. And so that's what this is reviewing here with you guys, just the findings that you would have in obstructive versus restrictive lung disease. So in obstructive, again, you have a low expiratory volume because you're having a hard time getting the air out, so you don't get much out initially. All right, so again, that FEV1 is greatly reduced. All right, I can't move much volume because I'm having resistance to that flow. There's a low FEF, 25, 75%, where the slope is lower. All right, and there's a reduced ratio, right? That was the 50% one. So if I make the ratio, I put FVC over here. All right, the total vital capacity you guys saw was actually lower in our obstructive patient. They don't move as much air because they tend to trap more, and more of that air becomes residual volume that they can't move. And so that would actually come down as well. However, because the numerator, the FEV1, goes down to a greater extent than the vital capacity, that's why our ratio goes down. It goes to less than 80%, which would be our normal. It goes down to, like, say, 50%, the example we just saw. In restrictive lung disease, again, you're going to have a low FEV1. All right, so it's going to be decreased. All right, you could have a normal slope. The slope could actually look somewhat normal because we basically inject 80 to 100% of that volume in restricted diseases. And like I said, the ratio could be normal or even elevated. So the FVC also comes down as well. The vital capacity is less than our example previously. It was about 3 liters was the total volume that the person could breathe in and out. And the ratio of the two, they usually are both reduced to a similar extent. So the ratio ends up being the same. It could be 80%. In some cases, the FEV1 is a little bit greater than the FVC. No, excuse me. The decrease in the total volume, I'm sorry, the decrease in the functional vital capacity could decrease to a greater extent than the FEV1, and so therefore the ratio would actually go up. It would go above 80%. It can go 80 to 90% or 100%. And so again, they would use these findings. If you see these patterns, okay, these patterns will basically tell you whether we're dealing with something that's obstructive or restrictive, but it doesn't give you the diagnosis of what type of obstruction or restrictive. You have to put that into clinical context, of course. All right. In some cases, for test-taking purposes, you can just kind of memorize that the values would look like that. Okay, but it's better to have an understanding. Okay, on this last slide, I want to just discuss with you something called a flow volume loop. So this is how the flow of air is changing during inspiration and expiration, and we can look at it graphically. And this will also help us to kind of figure out a diagnosis of, say, restrictive or obstructive lung disorder. So let me start with A over on the left side. So A is our normal, okay? And you'll notice on the x-axis is volume in liters, and you'll notice that the volume is 0 on the right there, and it goes up to about 6 or 7 as we work our way towards the left. So we're reading it from right to left there in terms of increasing volume. Flow is on the y-axis, all right? At the midpoint on the y-axis is the 0, not at the bottom, it's the midpoint. So in either direction, if we go down or up, there's an increase in flow. And flow, again, just like we talked about with minute ventilation, that's the amount of air moved over time. In this case, this is liters per second. So it follows the Ohm's law rule, because again, we're talking about airflow. So that's flow is equal to the difference in pressure over the resistance. So this person's total lung capacity, remember that's the entire volume, including the residual volume, would go from 0 up to, in this case, probably about 7 liters. That would be the total lung capacity. The amount of air we can move, though, we have to exclude the residual volume. So this graph starts here at this point, and you'll notice they mark it with an RV for residual volume. So it doesn't start at 0 because we don't move the air from about 0 up to about 1.5 liters in this case. So that's air that's not moving. So we're starting at this point. All right. So at this point, which is about the 1.5 liter mark, now when the person breathes in, during inspiration, the graph is going to deflect downward and to the left. And you'll notice that it increases, the flow increases up to a maximum about this point where we have our max flow. All right, the max volume moving over time there. So the reason this happens in terms of Ohm's law is that when we first start to breathe in and the lungs expand, we increase the volume and thus decrease the pressure in the lungs, and we create a pressure gradient from the atmosphere and into our lungs. So we actually, in effect, increase the delta P. And also, as we breathe in, as I mentioned on the earlier slides, we expand or increase the diameter of the airways because the tissue pulls them open as it expands. And so therefore the resistance goes down. That means that the flow overall is going to go up. So that's what we're seeing, is the flow is increasing to a maximum. But then on the other half of this curve here, you'll notice that the flow starts to gradually go down and reach 0 at the end of inspiration. And that also makes sense if you think back to the mechanics of it, because as we breathe in, we initially create that delta P, so air starts to move in essentially right away. As it moves in, it equilibrates that pressure. So what happens in terms of Ohm's law is we lose the delta P. We start to gradually lose that delta P because the air is moving into the lungs and equalizing. The resistance can still stay low, but if the delta P goes to 0, meaning it's completely equilibrated with the atmosphere and in the lungs at the very end of inspiration, then you're not going to have any flow anymore, right? Because if delta P is 0, then flow is 0. Now, in terms of exhaling, when we exhale, you see on the top portion of this graph, when we exhale, there's a steep upward curve, something we call the peak expiratory flow. And you'll notice that that goes up sharply and quite quickly, right? So what's actually happening here is that the resistance hasn't gone up yet. So when we expire, the airways tend to collapse because the lung is actually decreasing in volume. And so the diameter of the airways goes down with it. That decrease in volume causes an increase in pressure, so the delta P goes up. And at least initially when we forcefully exhale, very briefly, that delta P is greatly increased and the resistance hasn't really increased yet, and so the flow has gone up significantly. However, after that initial increase in flow, outward of course from the lungs into the atmosphere because we're expiring, you'll notice that the rest of the graph of expiration is linear. From that point, from the peak all the way back to the residual volume, it becomes linear. The reason is this. So let me get rid of these arrows. The reason is, although we're creating a delta P by trying to forcefully exhale, so the delta P is increased, after that initial peak, every increase in delta P we give by trying to forcefully exhale, there's an equal amount of resistance that goes up. Okay, so for every bit of effort I give to forcefully exhale, I'm actually increasing the resistance proportionately. So since they both go up at the same in the same proportion, it means that when I expire, it's actually linear. So it doesn't matter how forcefully I try to expire, the resistance goes up in proportion to that. And so that part of the expiration graph is actually linear. And so this is actually showing you here what this typical airflow or this volume loop looks like under normal conditions. Now let's take a look at B. B is actually showing us a pathology that is that sort of salmon-colored graph there. The dotted line is depicting the normal. As you can see, it's marked for you right there. So that's our normal. First thing I want you guys to notice is that our normal, the residual volume is somewhere over here where it's about 1.5 liters. The residual volume in this particular case is shifted to the left. Now, if you think just logically between restrictive and obstructive, which one would have an increase in residual volume? And that would be obstructive. So B is an example of obstructive. You can see that with the left shift in the residual volume. That could be your first clue. Simply because in obstruction, remember, we can more easily get air in than we can get out. Because to get it out, we already have something that's obstructed to begin with, so there's already high resistance, and when you breathe out, you increase the resistance. So it makes it difficult to get the air out, and so they have what we call air trapping. That makes the residual volume tend to go up because we can't get that air out. So if we look at the inspiration portion of it, right, again, the downward portion of the graph, the max flow is not as great, again, because we have a lot of obstruction here. All right, back to here, and you'll notice that the amount we can move. All right, it's a little greater than 7 liters there, but the total vital capacity has gone down. Okay, and by the way, to look at vital capacity on this curve, you just look at the difference between the residual volume. I'll draw it on the normal graph over here. The residual volume, and then the total volume that you see here. The difference between that is your vital capacity, the total amount of air you can move. And in our case here in obstruction, that total volume is actually less. That vital capacity is reduced, which we saw previously with the spirometry reading. During expiration, again, you don't get a good peak expiratory flow because the resistance is too high. And then you see the sort of scooped appearance. It's not quite as linear, and this has to do with some of the variability in the resistances due to the various types of, say, obstruction. Like if it's emphysema, at certain points during exhalation, it might tend to collapse more, and that would completely restrict or obstruct. Versus, say, someone who's asthmatic or has bronchitis, that scooped appearance might look a little bit different. But it's not exactly linear because the resistance isn't going up linearly anymore because of added factors like mucus and loss of parenchyma and so on. Now, over here at C is actually depicting, you see here, a little bit of a right shift relative to our normal residual volume. So think again logically in terms of the types of disease we have. Restrictive would have a smaller residual volume because it doesn't have much compliance. It doesn't open up as much, and so it's not going to be able to hold on to as much air. So it's the opposite problem of obstructive, right? And for the most part, restrictive is really just a compliance issue. It's not as compliant, doesn't hold the volumes as well. However, the flow rates can be very similar. So you can see that with the inspiration curve, looks very similar, and even the expiration. Some of the major difference really comes in is going to be in the vital capacities. All right, the vital capacity is going to be smaller. All right, so the vital capacity will be smaller, again, because the lung is constricted, it's not as compliant, it can't hold as much air. So oftentimes these graphs will look somewhat normal, often smaller than the normal, but the shape of it would look similar to the normal. And we have a little bit of a right shift. So when you're looking at this to kind of understand how the flow goes, remember just to look back at that Ohm's law. And we'll review this, of course, again in class with some examples.